Welcome everybody to the Independent Sage Friday briefing. This week we're focusing on the vaccination rollout. And this week we've seen more than 13.5 million people in the UK receiving their first dose of vaccine. And we're on target as a country to offer the vaccine to all adults over 50 by the summer. While this is a remarkable achievement, the emergence of new variants of the virus, which have originated in places as far afield as Brazil and South Africa, but also, of course, Kent and Bristol, is a stark reminder that viruses don't respect borders and will throw up new mutations, especially if they're freely circulating, and that nobody is safe until everybody is safe. So today, Independent Sage releases a consultation document on the global vaccine rollout, which Professor Anthony Costello is going to introduce shortly. And you'll also be able to read this report on our website later this afternoon. But first, as usual, we'll take a look at the latest figures and what they mean. Professor Christina Pargle, over to you.
Hello, everybody. So the latest numbers this week, it's pretty much a good news week. So I'm going to go through kind of the cases, hospitalization and death data, spend a bit more time on vaccinations and thinking about when we might start to see an impact in our data here. And then I just wanted to end with thinking about a couple of things to think about coming out of lockdown. You know, what might some of the challenges be? So cases first. This is number of UK confirmed cases by reported date. This is now coming down very steadily since early January, and we're back down to levels that we saw kind of beginning of December. This is really good news. And just looking at the percentage of people tested who are positive, which kind of takes account of variations in number of tests, you can see that this is also going down, and it's going down in each nation, again, pretty steadily over the last month. So that is also good news. The ONS infection survey released at noon today is entirely consistent with this picture, with Scotland having the lowest rates and Northern Ireland the highest, but everybody going down over the last 4 weeks. So again, that's nice. You've got two independent sources of data telling you the same thing. Looking in England, again, all the regions are going down. So that's good. You just want to check that it's kind of lockdown's working everywhere, basically. There is some difference, though, if we're looking at the size of things. So this is just looking at the week to the 6th of February, the most recent week that we have data for, and then the week before and positivity rate, which is these grey dots. And you can see that everywhere is going down. So the orange dot is below the grey dot everywhere. But in the East Midlands, the North East and Yorkshire, that drop is less. So things are moving a little bit more slowly in those regions. And again, that is consistent with what the ONS infection survey showed today as well. So this is good. This has been the picture now for a few weeks in England. But before we kind of get too excited about it, these green diamonds here show where we were at the end of August. So we have a really long way to go still before we get back to the low case rates we saw then, and we want to get even lower. We want to be in a situation where we never have another surge like we've had recently. This is just digging in to the actual number of cases. This is by local authority in England. And again, you can see that there are very, very, very few local authorities that have seen more cases this week. That's really good news. But again, those green dots at the bottom show where we were at the end of the summer last year. So it's just showing you we have a really long way to go. Even the very lowest case rates here are still higher than they were back then. So even though things are going in the right direction, we started from somewhere that was pretty bad. So it's a long road. Looking at hospitalizations, this is looking at the number of people in hospital per million people across the UK nations, because that's the most comparable measure between nations. Everywhere is coming down now, and coming down pretty quickly. Again, this is really good news, but everywhere is still higher. They still have more people in hospital than they did in the first peak. So, we thought this was as bad as it's going to get. It wasn't, and we're still kind of there now, and we've still got a way to go. Looking at hospital admissions, so new people arriving to hospital in England, that is coming down steadily, something like 25% a week. Took about 20 days for halving from here up to here. And again, you see this pattern across all the regions. So that's good. That's kind of basically, this is giving us confirmation that the case data isn't missing something, that really we are reducing infection across the country. But as I said, for occupancy, we still have overloaded hospitals, intensive care units in all regions, although they're now slightly not relaxing, but occupancy is going down a little bit week on week. They're still much higher than they were this time last year. So we're still in a situation where intensive care units and intensive care teams are very busy and really struggling. So we shouldn't be in a situation where we think suddenly the NHS is fine, because it isn't. Looking at deaths now, these are the number of new UK deaths registered from the Office of National Statistics and their equivalent in the nation. And you can see now that the peaks in the middle of January has now fed into this data, which is always a few weeks behind. And we've just seen these 2 weeks in the middle of January, or the end of January, with a really, really high number of deaths from COVID. And in fact, in the week to the 29th of January, almost half all deaths in England and Wales involved COVID-19. Just looking at these 4 weeks in the first peak and then this peak, we saw almost exactly the same number of deaths, over 32,000. So just these 2 sets of 4 weeks together is over half of all the deaths that have happened in this pandemic in the UK. And of course, what we haven't seen yet is this, the downward slope from here, whereas this does include that. But we are on the downward slope now. It's not going to get this high again, we hope. So this is the number of deaths reported within 28 days. This goes up to the 11th of February. You can see now that deaths are coming down, and we should see that reflected in the ONS deaths next week. And now that we are vaccinating and we're getting better treatment still, so for instance, the English recovery trial yesterday just announced quite a common drug which is effective against COVID. So given that, we should never have to experience such high numbers of deaths again. And if we ever do get into that situation, I think we can basically say that is a failure of policy. So now some really good news in the vaccination data. So this is a proportion of people vaccinated for each nation. This is up to the 10th of February, and you can see that we're pretty much at 20% of the whole population vaccinated. Wales is the highest at the moment, but it's all really good across the board. And over 3 million people received their first dose in the last week. So we have definitely met and exceeded the 2 million a week target. So this is definitely really good news. If we look at it just by age coverage, we're now in a situation where over 90% of people over 80 have had their first dose. Over 96% of people 75 to 79 have had their first dose, and almost 3/4 of people 70 to 74 have had their first dose. So this is really, really good. It means we've got really high coverage, and this will make an impact on deaths, and it will make an impact on hospitalizations over the next few weeks. But we have to be patient, because the impact does take time to filter through. So it takes about 2 weeks after your first dose for the protection from that to kick in. And then another 2 weeks before you might see that result in reductions in hospital admissions, because it takes about 2 weeks from infection to needing hospital if you get infected. And another week before you might die. So you would expect it to be 4 to 6 weeks before you see any impact in hospital admissions or deaths. And then, of course, it takes time to vaccinate. So in England, by the 3rd of January, we'd vaccinated about 1/4 of the over 80s. And so, that quarter, we might be seeing that impact, towards the end of January onwards, but we're still we've been vaccinating people all the way up this month. So, we can't expect to see a massive signal already in the data. So this, having said that, this is weekly hospitalizations for COVID by age group to the 7th of February. This is from the Public Health England report that came out yesterday. They've marked the start of the vaccine rollout here. And the other thing, of course, that's happened is that we've had lockdowns, so rates are falling in all age groups. If you really squinted at this graph, you might convince yourself that the admissions for 85 plus and 75 to 84-year-olds are falling slightly more steeply than, say, the 65 to 74-year-olds. But you'd have to squint. I mean, I don't think this is particularly definitive, but it's not a worrying thing to see. It's a potentially positive thing to see. Looking at deaths within 28 days of a positive test, Professor David Spiegelhalter's group in Cambridge looked at this, and they kind of have seen that it looks as if deaths in these two upper age brackets are falling quicker than deaths in the younger age bracket. Now, you can't say this is because of vaccination, but it is entirely consistent with a vaccination effect. And as over the next few weeks, we should start to see much clearer signals that you can say, actually, this is very likely to be vaccination. And the reason you can't say it's only that is because the effects of lockdown are really hard to disentangle from vaccination. The other thing that is consistent with it is that outbreaks in care homes have fallen a lot over the last 2 weeks. So they were pretty high through most of January, and over the last 2 weeks, they've really come down. And now that almost everybody in care homes has been vaccinated and most of the staff have been vaccinated, we should keep seeing that fall every week. And just want to kind of show you the experience in Israel, where they've now vaccinated over 90% of people over 60. And they are now seeing a big impact. They are also in a lockdown. They had a massive surge in the beginning of January. Their vaccination program started here. This is from a paper by Rossman et al. That was published this week. This was when their lockdown started, and this is when they started their second dose. So they are vaccinating people within 3 weeks, and they're using Pfizer. But you can see after about 5-6 weeks, you start to see this divergence. So this is new cases. So you're seeing that cases in people over 60 are falling much, much more steeply than cases in under 60s, which are actually pretty flat. And you're seeing an even more marked impact on hospitalization, where hospitalizations in younger age groups are still going up, but in the over 60s, they're falling. And so really what we're hoping is that we will start seeing that kind of really clear impact on deaths and hospitalizations by the end of this month and early March. We're probably, in a way, kind of in this bit here where it's just starting to diverge. What's slightly frustrating is that presumably the government has data on exactly who's being vaccinated, and they can track and see if that person then gets COVID or ends up in hospital. It's all linkable through NHS number. So there must be really good data around efficacy, which is really important given that we aren't doing a 3-week dosing schedule. So I'm hoping that the government will be publishing that soon, instead of kind of us having to kind of squint at the data and try to make sense of it. When we know that data must exist, it's just not public. And the other thing to remember, as we're thinking about relaxing restrictions and the government setting out its plan on 22nd of February, is that 90% of cases are in the under 70s. So the fact that we have now offered, or will have offered, the dose to everybody over 70 will not massively affect transmission rates. We have to rely on other interventions to do that. So just thinking about some of that relevant data, and these are just kind of things to think about as we're thinking about how do we think about coming out of lockdown. This is from the ONS survey, just road traffic data. And it's just basically just showing that this is traffic data in the first lockdown back in the spring. This is the November lockdown here, and this is the current lockdown. And what you're seeing is that actually we are moving around more than we were in the spring, but less than we were in November. So we're kind of in the middle in this lockdown. And a lot of that is people going to work. A lot more people are going to work this lockdown they did in March and April. But some of it also is shopping. More shops are open, and retail traffic it kind of mirrors this picture exactly, which is also in the same ONS report. So as we start thinking about coming out of lockdown, this kind of thing is going to increase. So more people are going to be out and about, and that has implications. This is looking at outbreaks in educational settings from the Public Health England report. And I've kind of shown this before. So this is kind of the start of term, and basically it's been pretty steady. There have been quite a few outbreaks in nurseries which are open, in primary schools where about 20% of students are going to primary school, and in special educational needs schools where about 30% of children are going. And we know in special educational needs schools, it's very, very hard to have social distancing there, because students need a lot of support from staff. Very, very few cases in secondary schools which have very few pupils in. So as we're thinking about schools opening, you would expect this to increase. And you can actually see that outbreaks in nurseries are higher than they were in November and December, which isn't to say you can't do it, but it's not open schools, closed schools. It has to be, as we were saying last week, how do you make schools as safe as possible to enable a return to education? And this is looking at case rate data by quintile of deprivation, where quintile 1 is the most deprived and quintile 5 is the least deprived. And what you can see is, particularly if you look at working age adults, which is like 20 to 40 years old in this case, that pre-lockdown, there's not that much difference between the different deprivation levels. And that's because a lot of people are just out and about. But once you have the kind of lockdown that we have now, the people who are still out and about and most exposed to COVID tend to be people in more deprived communities who are on lower incomes, who cannot work at home. And if they do work at home, they're often, or they are at home, they're often in more exposed areas and in overcrowded housing, where they're also more exposed to potentially getting COVID. So you can really see that basically it kind of stratifies it. So lockdown is quite unequal in that way, and that the people who are able to protect themselves from COVID, people like me, where I can just stay at home and work. And this is one of the reasons why, obviously, lockdown is a bad thing, even if it's necessary, as it has been now. But it also means that as we start opening up again and people start mixing again, you are creating a lot more situations for COVID to spread effectively. Everybody then kind of has the same exposure rates. And just finally, I think one thing to really think about as we're thinking about what to do next is learning from what's happening abroad. So I'm just going to highlight these 8 countries. And these are 4 countries in Europe, and they all have different levels of, the strain that was found in Kent, which is called B117, which is more infectious than the old variant. So in Denmark, about 20% of cases are now B117. They're in quite a hard lockdown. Schools and hospitality is shut. They started a lockdown in December, and they're continuing it for quite a long time, because what they're worried about is that B117 is spreading despite this lockdown. Cases are going up, and they're thinking it might be dominant by March in Denmark. In France, they've got about 15% of their cases are now the new strain. They do have open schools, but all children over 6 have to wear a mask. Hospitality is closed, and there is a curfew in place. And what they've seen is quite a slow increase in cases over the last 6 to 7 weeks. And they're really worried about this, because what they're worried about is that if the percentage of cases that are B117 keep going up, so if the new variant keeps spreading, at one point it'll just take off, which is kind of similar to what we had in England in December. The Netherlands is also quite interesting, because they are in lockdown. Their schools and hospitality shut, there are curfews. They actually kind of were pretty locked down over Christmas as well. And about half of their cases are now the new variant. And their kind of health ministry in mid-January released a report that what they're saying is that their lockdown is working for the original strain. So R was much less than 1, it was 0.85, but it was over 1 for the new variant. So that's kind of this idea, you've almost got 2 epidemics going on, where you're controlling the old variant, whereas the new variant can still spread because what you're doing isn't enough to keep it down. And you don't see it straight away, because if most of your cases are the old variant, that's where you see most of the impact. So what they're really worried about in the Netherlands, and that's why they keep extending curfews, is that because B117 is spreading, that they're about to have a big spike. Spain is also quite interesting. They are one of the few European countries that didn't have the pre-Christmas spike, but they had a post-Christmas spike, and they did have quite a lot of relaxation over the Christmas period. People could travel, they could have up to 10 people in their homes. And there they've got a really regional spread of the variant. Some regions have less than 5% of B117, some have up to 40-50% of B117. So they have regional travel restrictions, they have curfews, there's no household mixing. And whether schools and hospitality are open really varies by region and depends on the cases there. So at the moment, it is working for them. And this is just looking at these 4 countries. So there's the UK, Ireland, Portugal, and Israel. And the reason I picked these is because in all of them, the new strain is dominant. So, we know about the UK story. In Ireland, they now have at least 75% of cases of B117. They are in lockdown, hospitality is closed, schools are closed, but they're looking to have a phased reopening from next week or week after next. They actually had quite relaxed rules over Christmas as well. And they think that's what happened, is actually they had a lot of people coming back from the UK and they brought this variant with them. And then in January, things just exploded, which you can see quite dramatically here. So there was about 2 weeks where Ireland had the highest infection rates in the world. Portugal is something very similar. So B117 now is either dominant or about to become dominant. They're in lockdown, schools and hospitality is shut, and they're going to keep them shut for the next few weeks, at least I think it's till March. Israel also has B117 dominant. The good thing about that is it means we now know that Pfizer works perfectly well against that, so that's good. Their hospitality is shut. The schools have been shut, but they're now about to open, but they're doing the opening based on how many people have been vaccinated, but also how low case rates are. So it's similar to what we were suggesting last week, where you have to look at how prevalent is COVID in your community before you can open schools and something else. But they're still in national lockdown, despite the fact they've done so well in their vaccination. And really the reason I kind of want to show you this is because, the safest way to open, given that we've got this new variant, is to have cases really low. To have cases really low and to keep R below 1, and to do it by trying to make the things that we want to do as safe as possible. So it's not saying you can never open schools, but saying, okay, well, if we're going to open schools, if we're going to open shops, how do we do it in a safe way? How do we get cases really down? How do we reduce COVID in our communities and keep it down there? So just to summarize, cases, hospitalizations and deaths are now falling everywhere. Vaccination is going really well, and the next few weeks should see a clear impact. I hope the government will be publishing the detailed data of efficacy that they must have. And just kind of relaxing restrictions will be tricky. And I think next week we're going to be discussing this in a lot more detail. And the other thing that should be obvious by now is that variants are really the global concern. And that also means that vaccination has to be a global concern. So that's where I'm going to end.
Thank you very much indeed, Christina. And now Professor Anthony Costello is going to introduce Independent Sage's new consultation document on the global vaccine rollout. Anthony.
Great. Can you see that? Can you see my screen?
Yeah.
Okay, good. Thanks, Alice. So look, we're all in this together. And we all want to get back to work and a social life. We want to travel for business, holidays, maybe meet relatives. And our economy needs exports and imports. But we have a virus that knows no borders. Many countries in the world have very poor health facilities and systems. We're going to need border controls, whether we like it or not. And we face the risk of mutant virus outbreaks that could escape the vaccines that we have. And I'll remind you that there's a whole load of self-interest here. The cost to the world economy from the IMF estimate is that it will be $28,000 billion. Okay, massive. The cost to the UK economy, the headline in the FT today is the worst hit for 300 years, more than world wars, more than financial crises. And that's the scale of the figures there. And I'll point out that this morning on the radio, they said that 900,000 businesses are threatened with closure by April this year. And this is going to carry on for the next 3 to 4 years in various ways. So this is a massive issue. It's in our interest to get it right. So we need to have the world vaccinated. And we have COVAX, which is run by the Global Alliance of Vaccines and WHO as lead partners. They've got a vaccines pillar for a broader scheme of access to COVID-19 tools. And they want to do it so that they can pool their procurement, which gets prices down, and equitable distribution. But they face limited supply. At the moment, they say they're committed to 2 billion doses this year, but that's only 20% of lower middle income countries and even lower in the lower income. And I've seen one estimate of a $28 billion shortfall. Everyone thinks the WHO is this global megalith. Its global budget is less than my university, UCL. And when Dr. Tedros last February asked the world for a voluntary contribution, because they have to get the begging bowl out, for $675 million, he put out a call February the 4th last year. I saw him in Geneva on March the 4th. I said, Tedros, how are you doing with your call? And he said, do you know how much we've received? And I said, no. He said $1.2 million from Ireland, because Mike Ryan, the head of emergencies, had got on the phone to the Irish foreign minister. That's the scale of dysfunction in the world for addressing a global pandemic. And I think it's frankly shameful. Just look at this list of the advanced market, whatever it is. What's the C? Can't read it. Market commitments. Economies. There are 92 of them. That covers well over half the world's population. And you'll see that there are many countries there that you may want to visit. There's the Caribbean, there's India, there's Kenya, there's Nigeria, Pakistan. You know, we have Nepal, Rwanda. We have close links with almost all of these countries in different ways. And yet they are countries that don't have the capacity or finance in order to bring about vaccination. And we're looking at years of trying to get the world vaccinated unless we step up. We're facing mutant strains, the South Africa variant being the most worrying one. Lab studies have shown that antibodies have greater difficulty neutralizing this variant, the AstraZeneca particularly in the lab, and indeed clinically that the effect of the vaccine on mild to moderate disease has fallen substantially. We don't have any data on severe disease and hospitalizations except for one vaccine, Johnson & Johnson, which still retains 85%. So we must hope that that's the case. But we're going to see continuing mutant strains. And although we can adjust our vaccines, that's going to take time. The health infrastructure in lower middle income countries is very variable. Already nearly 20 million infants are under-vaccinated or not vaccinated at all. So that's something like 15 to 20% of the world's children, actually, for under ones. There's a huge deficit in oxygen ventilators, PPE, dexamethasone in many countries. And they will also need support to repair their existing immunization systems, as well as a push for COVID. So this requires effort, logistics, finance, and aid support. Now, 4 countries, India, South Africa, Kenya, and Eswatini, formerly Swaziland, have asked the World Trade Organization to lift intellectual property rights on vaccines. This, of course, is resisted by all the pharmaceutical countries who say that this will stifle innovation and incentives. John Arne Rottingen, who might join us when we formally release this document after we've had feedback, he chairs the WHO Solidarity Trial. He thinks that voluntary agreements are probably better and what's most likely to work, like AstraZeneca has a deal with the Indian Serum Institute, and they're already producing more than 50 million doses of that vaccine. But this is a big issue, and I think we will come back to it. So all we've done is made a few recommendations. We think there should be a global pandemic board to advise on the long-term response for vaccines in the UK, the consistency and fairness of border controls, and suppression of community transmission that we as a country have not done particularly well at, as we all know. But secondly, to ensure that UK funding for diagnostics, vaccines and drug development is linked to a tangible commitment for equitable global distribution. Clearly, it was a terrible error, I think, for the government to announce earlier last year that they were cutting our commitment that we've now had in place for 20 years of 0.7% of GDP for international aid. We need to continue to support that initiative, particularly in light of the COVID pandemic. And finally, that G20 leaders, there they are, our cohort of respected leaders, that we should get them together. Surely the G20 can come together to agree a global strategy and finance for equitable vaccine supplies, and not just dish out a bit of money each to COVAX, which is what they're doing at the moment. So I do hope that with President Biden now in the White House, we might see some leadership to achieve that. But I'll stop there. Thanks.
Thank you very much, Anthony. And that consultation document is going to be up on the website this afternoon, so you can find all the other independent SAGE reports there as well. Now we're going to open up to questions, and our first one comes from our special guest this afternoon, Caroline Lucas, Green MP for Brighton Pavilion. Caroline.
Thanks so much, Alice, and thanks so much, iSAGE, for all of your incredibly valuable work. It really is so important that you're doing it, and I'm really grateful that you're addressing this issue right now about global vaccinations. The head of the WHO, I think, called it a catastrophic moral failure, the fact that poorer countries still have so much less access to vaccines. And I think Professor Costello made a really powerful case, both the moral case, but also the enlightened self-interest case as well. And I just wanted to say, I tried raising this issue about how to share things like the intellectual property around some of these vaccines. I raised it with the Secretary of State on Tuesday and asked if the UK would change its position at the WTO and support South Africa and India to address pharmaceutical monopolies. And I think it would be fair to say that I was slapped down in no uncertain terms and basically told not to criticize the wonderful work of AstraZeneca. And I wasn't criticizing it. I'm very grateful that they are providing their vaccine at no profit. But I wondered if you had any thoughts or indeed any information about the issue around the transparency of that agreement. I mean, why is it the case? Do we know that an AstraZeneca jab is 3 times more expensive in Uganda than it is in the EU, for example? Do you think there's any chance that I might be successful if I keep pressing, asking for that contract to be put into the public domain, or is it just going to be something that they will never do? When it comes to a more global solution, I was interested, you kind of, I think, came around more to saying go for compulsory licensing rather than the TRIPS waiver, because it will probably be more effective, more likely to be agreed. But even with a compulsory licensing, I had a question as to whether or not, is it just a question of giving a poorer country a license? Presumably it's actually also a question of giving them all of the expertise and the know-how, and having experts from those companies being alongside some of the people in the developing countries, helping them to manufacture it. Someone made the analogy with a high-end recipe. You don't just need someone to give you the recipe, you probably need someone to kind of stand alongside you and show you how to make it, at least at first. So yeah, so the question really is around the transparency of the contracts, around how what else needs to be in place to make compulsory licensing work, and finally, if there's any modelling that might be possible that would show the impact of the likely emergence of variants in the north, if we do, and if we don't actually have a global solution.
Thank you very much, Caroline, for that fascinating question. I mean, there's a lot of questions in there involving politics and vaccine development,
inevitably,
and social justice. Who would like to start with that one? Anthony, I'll come back to you.
Just quickly, I'm sure Martin and Gabriel and others will have things to say. On the pricing, I would imagine that AstraZeneca would say that the reason Uganda and South Africa have to pay more is because probably they're trying to buy it from India. I don't know the details of that, but when you're in a market where there's huge demand and limited supply, and there are subcontracts that people can therefore charge more if they're, if India are going to release. I thought that India was actually only vaccinating their own people, but I just don't know enough about those markets.
Could we have required them to do that? Could the UK have said, or AstraZeneca have said, if you're going to be selling it on down the line, make sure it's always at cost?
They may have said. I just don't know. And even if they said, whether people would abide by those rules, I mean, look, I'm old enough to remember when the first polio vaccine came out. I was at primary school, and I remember a boy in the year ahead of me who had polio. And so, and the panic that caused. And of course, Jonas Salk, who invented it, and Sabin, gave the intellectual property away. And we have always had free polio vaccine. And I do think in this circumstance, and there may be growing pressure, I'm not completely agreeing with the voluntary rule. I think that actually the argument for suspending intellectual property for this particular vaccine is a good idea. And I'm reluctant to throw too much mud at AstraZeneca and Oxford, because they have actually come up with the most likely vaccine to be used around the world, and they committed to a no-cost provision. But I think this is a very complex area, and I hope the Americans are going to show the leadership we need to bring G20 together to solve it.
Thank you very much, Anthony. Professor Martin McKee.
Yeah, thanks, Caroline. Certainly compulsory licensing is a possibility. When we've got a letter that's been submitted to one of the leading journals at the minute where we look at this in a bit more detail. And we essentially said that the governments that are funding the research and development should have imposed a condition that then the intellectual property should be available worldwide, because otherwise essentially the citizens of the world are paying for these things twice, because much of this is funded, the research and development is by public money, and then other governments are having to pay for it all over again. So I think that would be the better way forward. It should have been done before. And I was just trying to check, there is a paper that is coming out in the Lancet today. Olivier Vouters from LSE and Andrew Pollard and others are authors on it, which I have seen, and I thought it was already out, but I believe it will be out very soon, which actually addresses a lot of your questions, and it looks at all of the vaccine candidates, what production capacity there is, and it argues exactly as you have said, like the high-end meal, that you need to have all of the elements. And it's not just enough to get vaccines into the country, as we've seen, for example, in France, which does have the vaccines, but then can't do that next bit of getting them into people's arms very effectively. You need to have an entire system in place, and there will need to be support for that too. But I'll send you that paper whenever it's up.
I can bring you in, Professor Gabriel Scally.
Well, I just wanted to say that one has to stress that it is in everyone's interest to have a sharing and a proper access to vaccines across the world. The possibility of developing new variants is absolutely dependent upon the amount of infection going on. So we should be sharing, even if it's not on altruistic reasons. We should be making sure that as many countries as possible get as much access to the vaccine as they can, and certainly should be targeted at two things: reducing death and disability, but also trying to reduce transmission and the number of cases. And I think it's deeply disappointing that people have sought so openly and greedily sought to make profit out of COVID-19, whether it be the contracts for PPE, which were scandalous. I think the contracts for the non-functioning NHS test and trace, again, another scandal. And here we have it repeating on a global scale. And if ever there was a time for humanity to show altruism and care for our fellow human beings, now is it. And Jonas Salk, Anthony mentioned Jonas Salk, and when Ed Murrow asked Jonas Salk who owns the patent on the vaccine, he replied, well, the people, I would say, there is no patent. Could you patent the sun? And if that was an appropriate thing to say about polio so many decades ago, surely the world is now at the stage where we should say that there are no patents on anything to do with COVID-19.
Thank you very much, Gabriel. And Professor Carl Friston, you'd like to comment on the modelling aspect of Caroline's question?
Yes, I can't really comment in a very informed way, but there certainly has been some sort of high-end modelling about how it is best to use vaccines. And my reading of the literature is that it depends very much on the availability. So if you've got loads of vaccine, the best way to help is to protect the clinically vulnerable. On the other hand, if you haven't got very much vaccine, then you target transmission. So you target those people who can transmit the virus. So dictating very, very different sort of deployment strategies depending upon the availability. I repeat, I can't speak to the specific models, but what you want to look out for is the key issue you brought to the table, which is this notion of immune escape. So if it's the case that you focus on the clinically susceptible and ignore the transmission imperatives, then you are creating an opportunity for immune escape. So, in terms of the modelling, that's what you want to look out for. And I'm sure people are working on that.
Lovely, thank you.
Thank you very much, Carl. Thank you for your question, Caroline. I'm going to move on now to the next question. It comes from Dr. Alex Sowell, who is a GP in Tower Hamlets. Alex.
Hi, you can see me. Okay, great. Hi, yes, and thanks for inviting me to ask a question here, giving me the opportunity to learn from your expert panel, and I hope that maybe you'll take something away from my 140 general practice colleagues' collective experience of listening to many patients every day over the last 11 months, including yesterday. So our question really is, why is the UK COVID case definition not in line with the WHO COVID case definition that includes many other recognised symptoms of COVID-19? We're asking this question not because of the recent REACT study data from 1 million, nor the ONS community data that I don't think asked about runny nose, but as we're asking this question because every day in general practice, we're dealing with patients' most pressing health needs, and we're regularly inadvertently picking up on other symptoms that patients deem to be unimportant, symptoms that they have not even considered could be COVID, because firstly, the national publicity campaign highlights cough, high temperature, loss of smell and taste. And so our patients take this to mean that other symptoms are not COVID. Secondly, the Royal College of Paediatrics and Child Health Guidance for Schools still states that colds don't require COVID testing, and this has a profound effect on the understanding of teachers, children, parents, their communities on what COVID is. So I've regularly come across a scenario where I've advised a parent that their child needs a COVID test, and they tell me, no, the teacher said it's just a cold. And I've come across teaching staff that have gone to school with colds, then tested positive for COVID and been absolutely aghast that they've been to a school probably spreading COVID because they had been following the guidance. And then thirdly, rightly so, the media focusing on severe hospital cases, but in the same breath, that makes it very difficult to convince our patients that their mild illness could be COVID, because COVID, community COVID cases are not the same as the ones that end up in hospital. So shouldn't the public health messaging, the adverts, be telling the public, especially my patients, many of who are the 8 million going to work every day, their employers and the teachers of the 1 million who are in school every day, that even those with mild symptoms, not just a cough or high temperature, could have COVID? And I guess this question isn't just about which symptoms in community COVID have the greatest positive or negative predictive values and accuracy, or what the testing criteria should be. For me, it's got more fundamental components to it that I'm trying to get to, which is that good medical practice ethically demands that in individual patient consultations, GPs are honest and we explain to our patients what their possible diagnoses are and the risks of those things. And alongside that, in our democracy, isn't there a moral obligation for the state via public health interventions, adverts, to also be honest and explain to the UK population that COVID can present with other symptoms? And isn't that one of the key differences between the UK and countries that have suppressed their epidemic without going into an indefinite lockdown, that others have paid attention to the mild symptoms of COVID, and which decreases the time between a person being infected and self-isolating, that fundamentally really depends on the individual having that knowledge. And only then can you expect all the things about supporting self-isolation, employment practices, which are important, but they don't even not relevant to me at the grassroots. And so coming back to my question, isn't it vital that we should be changing the UK COVID case definition to include things like coryza cold or acute sneezing, vomiting, diarrhea, symptoms that conceivably have the greatest potential for infectious spread, making it consistent with the UK, which is just so important in schools, rather than urging students with runny noses to wear a mask all day?
Alex, thank you for your question. I mean, what I'm getting there is a very complex picture of what you're seeing in your patients, but also an enormous amount of frustration amongst GPs, but also amongst patients as well. Professor Christina Pargle, you'd like to comment on this?
Yeah, just to say that I think they absolutely should, expand the list of symptoms that makes you eligible for a COVID test. Not least because I think some people who know that there are more than just those 3 symptoms are just kind of pretending that they've got them to get a test, rightly, because there are so many more, especially for children who often have quite different symptoms to those classic 3 symptoms. I think probably originally when they did it, it was because they didn't have that much testing capacity. But we have now got good testing capacity in the UK. We can test millions of people a week. We are testing millions of people a week. We should now be expanding the symptom list, telling people about it, having the public information campaign, so that we can really pick up as many cases as we possibly can to keep case numbers down, which is what we need to do.
Thank you very much, Christina. It does seem like the sensible approach, doesn't it, as well as the honest one. Dr. Zubaida Haque, and then I'll come to you, Gabriel. Zubaida.
My biggest fear is, Alex, is that part of the reason the government haven't expanded the definition of the COVID symptoms is because they've put politics and wealth before health. And the reason I say that is I think part of the reason is because they invested over 22 billion in a failing test and trace system. They invested the test and trace system with people who didn't have expertise in the area. They completely avoided the public health system. They completely avoided public health professionals who knew how to do test and trace. And instead, they went to private companies that had no expertise. And of course, we saw very early on in the pandemic, we saw last August that those companies were failing to do the testing, were failing to do the tracing. And it was at that point, at the end of last summer, when we got the message from government saying, unless you have very specific symptoms, do not come forward. Do not come forward for testing. And as we've seen, Alex, and as you've rightly pointed out, the very people who have been failed by that poor public health messaging, and because the system couldn't cope, because the privatized and centralized test and trace system couldn't cope, are the people who are on low incomes, insecure jobs, and the most exposed to this virus.
Thank you, Zubaida. And Gabriel, you wanted to comment?
Yes, it's a really important issue you raise, and there is absolutely no reason why there shouldn't be a lot more education and publicity around the full list of symptoms so that people can make a judgment based on what symptoms they actually have, rather than this list of 4. And the list of 4 was a UK creation. For example, the Republic of Ireland has a list of 5 things, including shortness of breath, not inappropriately for a disease that has major respiratory symptoms. And they were put together, as Christina said, on the basis of access to testing. They were designed at a time when testing was limited to make sure that the numbers were copable with. But that is no longer a problem, and they should be shifted, no doubt about it. But even more important is how that translates then into getting a test. And one of the key areas that needs more attention is the close contacts. Because at the moment, close contacts, as you undoubtedly know, are not tested unless they come forward with symptoms. And that is outside the European Centre for Disease Prevention and Control guidance. It's outside the guidance from CDC in Atlanta, who say that all close contacts should be tested. And that's one of the reasons why the Republic of Ireland did really well in the autumn, because that's what they do. And they've just decided now to expand their testing of contacts to do it on day 0 when the contact is notified, and also on 10 days irrespective of whether they've got symptoms or not. So you're quite right to raise the whole issue, and it does raise very, very serious concerns about the whole design of this testing and tracing function. It just doesn't work.
Thank you very much, Gabriel, and Professor Susan Mickey.
Thank you. Yes, I wanted to broaden it a bit to actually even thinking about finding people who have the four most common symptoms. I mean, the government talk about test and trace. We keep talking about test, trace and isolate, because there's no point testing and tracing unless you have good take up of the isolation. But the WHO talks about find, test, trace, isolate and support. I support to isolate. And I think what you're raising is that the find, because, you know, if you're missing people with all these other symptoms, you're missing them. But also, if people aren't aware of what the symptoms are, you're missing those people anyway. And we do weekly surveys of 2,000 people across the UK. And still, even to this day, for the four most common symptoms, or the four stated symptoms of COVID, only 3 out of 4 that are asked are aware of them. So 1 out of 4 is not aware that that's a symptom, whether it's a cough or whether it's high temperature, loss of sense of smell or loss of sense of taste. So this is a very large number of people. And as you say, if the government were serious about managing this, we send them this data. They have had these data come to them since January, when the numbers weren't much better. They would be doing a massive campaign and targeting those people who still aren't aware of the symptoms. If they're not aware of the symptoms, then none of the rest of it follows. So I completely agree with what you're saying about broadening the symptoms, but let's not forget that a quarter of the population still don't know what those 4 symptoms are.
Thank you very much, Susan, and all the other respondents there. And thank you, Alex, for that fantastic question. Moving on now to the next question, which comes from Bev Ferris, who's editor of the Business Travel magazine. Bev.
Hi, everyone. As you would expect, my question is relating to travel. So do you expect the current travel restrictions to be enforced for the foreseeable future? When can we reasonably expect companies to be able to restart both domestic and overseas business travel? Are we likely to see more countries added to the red list as new variants are identified? And is this all too little, too late?
Thank you very much. Who would like to start asking this question about travel? What do we think about the likely lifting of restrictions? Gabriel?
How many questions was that, Bev? I lost count there along the way.
I think it was 7.
4. So do you expect that the travel restrictions to be in place in the foreseeable future?
Well, let me start with your last question. Was too little, too late? Absolutely. We should have had travel restrictions on public health grounds right from the very beginning of this pandemic. So, and all the way through, actually. And I expect them to last some time, not in their present form. I think the current form is entirely inadequate to identify these 33 countries, or whatever the number is today, where arrivals are expected to be in managed isolation is a step forward. But as anyone who travels a lot will know, it's perfectly easy to route yourself and not have through ticketing and avoid the restrictions. For example, there are great reports of, very strong reports of full planes from Portugal arriving in Dublin in the last week because there are still direct flights going to Dublin, and those full planes carried people undoubtedly that got onto a plane to somewhere in the UK afterwards. So I don't believe the restrictions are adequate at all, and we need to move to a proper managed isolation system. You mentioned business travel, and some countries in the world, Taiwan, for example, have set up special arrangements for business travelers, which I think are sensible and safe. But I was hugely alarmed when I went on the government's site for the self-isolation regulations and found the huge number of exemptions there were to self-isolation, which included, everything from bus and coach drivers to people who were bidding for the next round of national lottery franchises, and a huge number, and entirely unsatisfactory. If you're going to do these things, the only way to do them is do them really professionally, do them really well, and make them work for us. Otherwise, they just act as a frustration, and people dismiss them because they're not having any effect. And I think they will be with us for some time. I hope that we see effective restrictions rather than tokenistic restrictions.
Thank you, Gabriel. Professor Stephen Reischer.
I think it's instructive to compare what's going on in the UK today with what's going on in Australia today. Because in Australia, they've had an outbreak of 13 people, 13. And that has led, in the state of Victoria, to an emergency lockdown, which will probably last for about a week, in order to get on top of cases, to trace thousands of contacts from those 13, because they have an efficient system, in such a way to stop it spreading. As a result, Australia, number one, has had 909 deaths, while we've had over 100,000. Number two, its economy is growing, whereas our economy shrank by 9.9% last year. In Britain, we have something like 13,000 cases a day still, 13,000, 1,000 times as many. And people are talking about opening things up. And even our quarantine system, number one, is, I mean, it's a ridiculous system. It's a bit like bolting the front door against an intruder while leaving the side doors open. I mean, it's ridiculous. And we also discovered today that the actual quarantine is softer than it is in Australia, for instance, in terms of allowing people out, in terms of PPE for the hotel staff. And the real problem is that if you have half measures, as we have in this country, if you have fudges, then they achieve all the disruption, but none of the advantages. And what we see around the world is that if you act fast, and if you act hard, it's not only good for public health, it's also good for the economy. So absolutely, we need to secure our borders, because in that way, we are more likely to be able to contain things domestically and open up domestically. When we're able to open up internationally is in large part dependent upon the issue we were discussing earlier. That is supporting countries elsewhere to get on top of things in their own countries through the vaccine. And it's another example of enlightened self-interest. Only if we support a solution at a global level while taking things seriously at a local level. And of course, controlling borders is not just about stopping people going in, it's stopping people going out and spreading the variants we've got around the world. Only if we do that are we likely to be able to get on top of this. So when you go hard and when you go early, you control the virus. If you dither and fudge, then the virus controls you. And I think that's the simplest and clearest lesson we've had so far from the whole pandemic.
So sorry, Beverly, if that wasn't quite the answer you were looking for, but extremely important to keep a lid on new cases coming in and going out. Moving on to the next question now, which comes from Nigel Nelson of the Sunday People. Nigel.
Thanks, Alice. I'm looking forward to your Stonehenge documentary later on tonight. Christina said that it takes 2 weeks before the vaccine is affected. Does that mean you have no protection from serious disease until day 14? Or is there some immunity that comes from day 1? And if so, how much? Can this be quantified?
Thank you very much. So that's a kind of virology question. How does that immunity appear? Does it swoop in quickly at the end of those days, or does it gradually accumulate over time? Quite like Professor Dean Pillay to be here to answer that, but he's not with us today. Who would like to take it in his absence? I'm going to pick on somebody. Who am I going to pick on? Anthony, thank you.
Well, I'm not a virologist or an immunologist, but as I understand it, it's a curve that goes upwards. I I had a vaccine a week ago and I didn't have any side effects. So I suspect it's my first exposure. And I would guess now I would have very little protection, although the process of creating the various antibodies, IgM, IgG, is starting. And the advice is based upon what happens in most people of young or middle age. Now, older people have a slightly slower response. And so 14 days will be the earliest that they're going to get decent protection. But it is a gradual thing. So it's very difficult to say, you know, day 13, you're completely unprotected and day 14, it's fine. It's obviously not exactly like that. But I think the guideline is that you should take all precautions of protection, certainly up until 14 days and probably 21 days if you're over 70. And of course, it will vary from person to person on a whole number of other factors as well. But that's an amateur opinion.
Thank you very much. It's a fairly informed amateur opinion, though, Anthony. Martin McKee.
Yeah, I mean, if you look at the lines of from the clinical trials, what you see is that in people who've been vaccinated and the controls, they really move absolutely together up to about 14 days. And then there is a clear division in that it goes flat in the ones that were vaccinated while the cumulative cases continue to rise in the others. But as Anthony says, certainly for older people, it does seem to be that you need at least 21 days. And the other thing that we're seeing now is that immunity does seem to increase with even longer, and so it does continue to rise in the longer term. And so I think you definitely should not be taking risks in the first 14 days. And one of the things we've seen in Israel was that there was an increased number of cases in people who had just been vaccinated. And it's thought that this is probably because they did feel that they were safe and it was rather premature.
Thank you very much, Martin. I'm going to move on now to some questions from members of the public, starting with Richard Cottrell from Monmouthshire. Richard.
Hello, very quick one. With the Kent variant now reported in 50 plus countries, do all the cases originate from the same common source, or is the virus mutating independently in the same or similar way in different countries?
Thank you very much for that question. So do all of those apparently Kent variants come from one original Kent variant? Martin?
Well, first of all, the Kent variant is itself further mutating. What we are seeing is that there are certain variants which are appearing in a number of countries, which are the same mutation, which do seem to give the virus an advantage in its transmissibility. Of course, there are lots of other variants as well. One of the big questions, which is as yet unanswered, in fact, there was a paper just out which is beginning to look at this, looking at modeling of the potential variants that could arise in the ability of the virus to bind, is will we eventually get all of these mutations towards a variant of the virus which is maximally fitted for transmissibility, and then it's sort of any deviation, any further mutations beyond that reduce the binding ability, and that's not yet clear. In fact, Christina and I were involved in a Twitter exchange on that earlier, but I think the evidence is certainly accumulating in that, and hopefully we should have an answer fairly soon. But the answer to your question is the same mutations are appearing in different parts of the world.
Thank you, Martin. Christina, do you want to comment at this point?
Well, just say that if someone sequences it and they call it the Kent variant or B117, then it's the same lineage. But as Martin said, that there are other variants that have found the same mutations that have the same effect. So it's both, I suppose. But they can tell from the sequencing pretty much it looks like the exact history of the different strains. So if they say, oh, it's B117, then it's got the same lineage.
Okay, thank you.
Thank you very much for that question. Moving on to the next one. It's from Andrew Russell in North Yorkshire. Andrew. Are you there, Andrew?
Hello, yes.
Hi.
Hello there. Like many people without a scientific or medical background, we've had to make important personal decisions on how to stay as safe as possible. So my immediate family have been amazing in shielding me, often reliant on discussions such as those that happen here, even down to who gets a haircut and who doesn't. My question is about the coronavirus variants we hear about. So if I've understood things correctly, the UK and elsewhere, there are different strains of coronavirus that compete with one another. If that assumption is correct, and with research showing that the South African variant may be less responsive to the likes of the AstraZeneca vaccine, do you think it's inevitable that the South African variant will eventually become the dominant one? And I suppose in broad terms, how worried should we be?
Thank you very much for that question, Andrew. It is always an arms race, and you haven't won it when you've started developing vaccines, clearly. Martin, you look as though you're keen to start with this one.
Yeah, well, it seems like the South Africa, we have to be hesitant about the geographical descriptions, but let's just use the South African and the Kent variant. They do seem to be similarly transmissible because of the variants they share. And that being the case, there's no reason why one should dominate over the other. The Kent variant was clearly more transmissible than the version that went before, which was more transmissible than the original variant that came out of Wuhan. So there's an issue of transmissibility, and it's only if the variant is more transmissible that it will take over. Then there is the question of vaccine escape, although the reassuring evidence, certainly with the Pfizer-BioNTech vaccine, is that even with the South African one, there does seem to be this other T-cell immunity, which seems to be working because it seems to be directed against a different part of the virus that hasn't mutated. So that is quite encouraging. So we just need to wait and see what's going to happen, I think.
Thank you very much, Martin. Zubaida.
I think, Martin, this is why we need to go beyond vaccination. At the moment, it seems that the only strategy we have out of this pandemic is lockdown and vaccinations. But lockdown and vaccinations, while bringing down deaths, are not going to bring down cases and are not going to keep them low. That's why Independent Sage has said right from the beginning that what we need is a test, trace and supported isolation system. And we see places like Newham, local authorities like Newham, who have finally heard messages like that and who are investing in hotels for people in overcrowded housing, for people from lower income backgrounds and so on. And that's the important bit. It's the test, trace and supported isolation that's fundamental in bringing the cases down, and that will ensure that there's less likely to be mutations. Sorry, that's my puppy. I'll stop there.
Can I just say I totally agree. And of course, a virus that does not replicate does not mutate. And that's why we don't have other variants of the SARS virus that we had in 2003, because it hasn't been circulating. So 100% agrees about it.
Thank you very much, Martin. And that takes us back to Anthony talking about the altruistic and completely non-altruistic reasons for bringing down the infection right across the globe. Carl Friston would like to say something briefly. I do want to squeeze a couple more questions in though. Carl.
Yeah, just to reinforce the point about viral competition. So again, I'm not an immunologist or virologist, but I do know about evolution. And there can be one common thing is the sort of competition between the viruses, leading to things like Red Queen dynamics. And we see that, in fact, we saw it in Christina's presentation, where basically the coronavirus has beaten the seasonal influenza virus. So it's not necessarily the case that there's going to be one winner takes all. There could be fluctuations, and you can look at the existing variants as providing a herd immunity via cross-immunoreactivity to new variants. So there may not be a final outcome where everybody has the South African variant.
Thank you very much, Carl. I'm going to move on, try and squeeze in a couple more questions. We have Priti Basin from London. Priti, are you there?
Hello, thank you for all your help so far. So the question that I had is that what can I do as a member of the public to play a part for global vaccine immunity? And if there is something that I can do, then if you could say it like in practical steps.
Thank you for that question. Anthony, what can individuals do? It does seem like this sort of massive geopolitical problem. What can we do as individuals to help?
Well, as a philosopher once said to me, as individuals, that's all we can do. So I would recommend writing to your GP, your MP, sorry, your Member of Parliament, and putting pressure on to your local representatives about the importance of having this, and putting pressure on the media to respond to this kind of need, and to say, why are we not funding our global systems for vaccine production and distribution, because it's all in our own interest. And whilst I really hope that this vaccination policy will quickly lead us back into a more normal existence, there is this great worry of vaccine escape and new variants and the rest. And therefore we have to be absolutely aware of the self-interest component of a global vaccine campaign. So I think anything you can do through your networks to put pressure on decision makers, on the media, and to raise the issue is something that's worth doing.
Thank you very much, Anthony. Susan, you'd like to say something here?
Just to say, in terms of the kind of zero COVID strategy, there's now a national zero COVID campaign that brings together community groups, professionals, trade unions, all different types of people. And I just wonder if at some point, and whether you might be part of it, I don't know how these things arise, but whether there could be a similar UK campaign for global justice for vaccines. I think it's very much needed. And then that can help get pressure on MPs and everyone else and raise awareness in general. Maybe a petition is a way of starting something.
Start making your voice heard. Gabriel, you'd like to say something?
Yeah, it's a great question, Priti. I think one of the issues that could be taken up with MPs in the media and on social media would be what's going to happen to the 407 million doses that the UK has ordered. That at the moment, given that they're not approved yet for under 18s, is probably enough to vaccinate the population with 2 doses 4 times over. And what the government may do is release those to the highest bidder. I don't know what they have in mind, but it is a fantastic opportunity for the UK government to help the rest of the world. That's a huge amount of vaccine that could be used for humanitarian purposes across the world to help us 2 ways. Firstly, help those countries preventing deaths and disability, but also preventing the transmission of the disease and the replication of the disease. And my fear is that at its worst, the government might try and sell on those options or sell on that vaccine and try and make a profit for itself. Who knows what this government would do? But here is a real opportunity, those 300 million doses that are going spare.
Thank you very much, Gabriel. Thank you, Priti, for that wonderful question. I'm going to squeeze one more in. We're running up against it, but I'm sure we can do it. John Hebden from BCB Community Radio in Bradford. John.
Yeah, thanks, Alice. So some of you may be familiar with the work of Professor John Wright at Bradford Royal Infirmary. So he's doing a weekly blog with the BBC. And he reported last week that 46% of people aged 80 or over in the Pakistani community in Bradford have been vaccinated, and 23% have refused the vaccine. So that's out of a population of about 1,800 people in that group of over 80s. Wondered if the committee had any experience or advice that they can share in promoting vaccine take-up with particularly vaccine hesitant communities.
Thank you very much for that important question, Zubaida.
That is a really important question, John, and I think especially in the context of the fact that on Monday we are supposed to be reaching 15 million people vaccinated in this country, not only being offered the vaccination, but also quite possibly being vaccinated. But there is no point vaccinating people, or there is no point certainly in having a vaccination system, a vaccination program, if that is entirely undermined by vaccine hesitant groups. And we know that that's a particular issue with Black and ethnic minority groups. We know that half of Black groups over the age of 80 have been vaccinated in comparison to white groups. And we know that, of course, it's lower among some Asian communities, including, as you mentioned, in Bradford. Now, there are quite a lot of things that need to be done, and we're seeing some of it being done locally with faith organizations, with community organizations. But actually, John, what we need is this to be led by the government nationally, working with local public health professionals who are more trusted. And trust is essential when it comes to vaccine hesitancy. We know that it's trust in institutions and trust in vaccines that are two of the key issues here. But we need this issue to be led by government with a strong public health messaging campaign similar to the Stay at Home campaign.
Thank you, Zubaida. I think, Susan, you'd like to just come in quickly there.
Yes, I put on the chat that the Scientific Advisory Group on Emergencies, SAGE, has published a really excellent paper on increasing vaccination uptake in Black and ethnic minority groups. And it was led by Kamlesh Kunti, who's also a member of this group, but couldn't be here today because he's in clinic. So I hope to be able to get you the link before the end of this, but I don't think I will be able to. But if you email me afterwards, I could send it to you.
Thank you very much, Susan. Thank you, John, for that question. I'm going to draw things almost to a close, but I pass over to Sir David King for a summary. Sir David.
Thanks very much. I think once again we've had a very good discussion, and the only question in everybody's mind is the government listening? So first of all, in terms of vaccines, I think the report we've heard today was critically important. We know that this is a virus that is mutating, but it only mutates in those parts of the world where the density of the virus is high. Otherwise, if the density of the virus is low, the mutations are very ineffective. So what we know is that it is in our self-interest to see that global vaccination takes place and takes place as quickly as possible. We are looking at a possibility of a 2-year rollout of vaccination to reach the developing countries of the world, and that really is far too long. So we in our own self-interest, because as a new variant appears and perhaps is no longer dealt with the current vaccines available, we all know that it could simply carry on until we get this new family of vaccines produced. I'm going to come back to the point that I always raise. Do we have a coherent strategy in this country to bring this pandemic to an end? Or are we just relying on vaccines in Britain alone to deliver the end point to the pandemic in this country? Our fear is that this second big wave may well be followed by yet another wave unless the strategy that we have been pursuing for so long of find, test, trace, isolate, and support, the global strategy developed by the WHO, we really want to see that rolled out properly. And when I stress this, I have to say, it's the support system for those who've been told that they have to isolate themselves from the rest of the community that needs to be operated, and it's nowhere near ever delivering what it was needed to do. So the question now in everybody's mind is, when do we come to the end of lockdown? Now, of course, that's a critically important question. And my answer would be, we can't surely come to the end of a lockdown again when we get down to a certain number of cases in the country. If that number of cases was 1,000 in total of people who have the disease, that's enough to spread once again. We all know this. What we need to do is make sure that every one of those 1,000 are actually isolated and all of their contacts. I leave you with that. We need a strategy, please, to take us out of this lockdown and not allow us to return to, once again, another wave and another lockdown. Thank you.
Thank you very much, Sir David. Thank you for all of your questions today. Thank you, everyone watching, if you're with us live or catching up. Thank you to Independent Sage for their amassed expertise. Everyone here is a volunteer and they're doing it because they think this conversation is important, not just the open sharing of data, analysis and scientific perspectives, but being here to listen to your concerns and questions as well, and hopefully support you in that way. The consultation document on the vaccine rollout and all of the Independent Sage reports are available on the website, along with details of all the scientists. Please follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Stay home if you can, stay safe, keep well. Thank you, everyone.
Thank you. Bye-bye.
Bye.